Hey everyone, my name is Joy. Videos tend to be easier for people to watch than to flip through slides sometimes, so I decided to include one along with my PowerPoint presentation. For my eukaryote project, I chose Ascaris lumbricoides, the giant roundworm. So let's meet Ascaris lumbricoides. It is one of the most common worm infections worldwide, with over almost 2 billion people infected. This is a very large roundworm. Yes, even larger than you're thinking. It is 15 to 40 centimeters long, and that's over 15 inches. So the males are slightly smaller, if you can call that slightly smaller, 15 to 31 centimeters. But that's still a massive roundworm. The males have curls at their posterior ends, and the females are straight. And there is a cousin species, the Ascaris suum, found in pigs. Think of suey with pigs. So the Ascaris suum is found primarily in pigs, whereas the Ascaris lumbricoides is found primarily in humans. And there is some debate as to whether these may be the same species. They've done some DNA analysis, and they're still not really sure. So the debate is still out on that one. All right, so looking at the male and female comparison, you can see here that the female is very straight right here, and then there is the curl at the posterior end of the male. Now the females, like I said, they don't curve, but the first third right here is the vulva, which is followed by the uteri. And the uteri may contain up to 27 million eggs, of which they lay 200,000 per day. So if we're going to label these worms, we would put this one on the left would be female, and the one on the right would be male. And we know that this worm is actually upside down because the curl goes towards the ventrum. If you think of dorsal as being at the back, ventral is to the front. And so if the males have a ventral curve, we know that that is this way. And so he is upside down in the picture. All right, so the transmission to humans. Humans and pigs are the primary hosts of the Ascaris. And there are eggs that are occasionally found in dog feces, but they don't believe that dogs are actually infected by the worms. They don't actually take up residence in the dogs. It's just a spurious presentation. And so the eggs and the worms are transmitted through the fecal-oral route. It's the fertilized eggs that must be ingested. Now, these eggs and the transmission of the worm, this can take place worldwide, but that especially takes place in tropical and subtropical areas. So just for a reminder of that, if you'll remember from elementary geography, we have the Tropic of Cancer and the Tropic of Capricorn, and these lines of latitude are what define the tropics. But what may not have been covered in your class was the subtropics, and the subtropics extend out beyond the tropics. And we can see on the map here that the subtropics actually do extend across the lower part of the United States. And so you can see that the southernmost part is well within that area of the subtropics. And of note are the eastern parts of the southern United States, which has both the humidity and the clay that the Ascaris worms are that they prefer. All right, so now we get into the infection cycle of Ascaris lumbricoides. And it's kind of hard to find number one on here, but it's in this box that shows the worms. It's just showing you the females and the males. Note the male with the curl. All right, and the infection cycle begins when a host defecates feces containing the Ascaris species eggs. But only the fertilized eggs are capable of continuing the cycle. If the eggs have not been fertilized, then they will not go on to infect somebody. So when we look at these eggs, you can see on the left that there is a fertilized egg, and it's very round. And the unfertilized egg, even though it has the same tough coating on it, it is unfertilized, it is not infectious, and it's very ovoid. Now, because of the coating that's on here, These eggs can resist strong chemicals, they can resist desiccation, the drying out that can happen while they're in the soil, and they can resist low temperatures. And this allows them to remain active in the soil for up to 10 years. All right, so we're moving on through here, and we've eliminated the unfertilized eggs out to the side. So if we continue around the circle, we can see that the fertilized eggs are going to begin to develop. But it's not until they reach the point that they are embryonated, that the worms are really starting to form within the eggs, that they become infectious when they are swallowed. And so if we see up here at the very top of this chart at number 4, there's a little biohazard symbol. That's when that infective stage begins. That's the ingestion of the embryonated eggs. And only those fertilized embryonated eggs are the ones that are infectious. So at that point, if they are consumed, they do have the potential to cause infection. So when the eggs are swallowed, they're stimulated by the gastric juices in the stomach. They then hatch in the duodenum, and then they migrate to the cecum, which is down in the colon. And so from there, the immature worms burrow through the epithelium, think of that thin lining of the colon, and they enter portal circulation and travel to the liver. So you think about, there's all this rich blood tissue in the intestinal area. And a lot of that, it goes back into portal circulation. It's all being absorbed by portal circulation. It's going through those veins up near the liver area. And so when the immature worms burrow through that intestine, they're entering portal circulation. They're going up to the liver, and that obviously can cause problems. And so you can end up with a hepatobiliary ascariasis when the worms have left the intestines and they end up in the liver. Now, they're not going to stay in the liver. There is nothing that they actually want in the liver. They're going to continue out of portal circulation, and they're going to enter the inferior vena cava. We know that the liver drains into the inferior vena cava. And it's going to then migrate into the heart. And from the heart, we know that the blood circulation leaves through the pulmonary arteries and goes over to the lungs. And that is where the worms are going to hang out for a while. They are actually going to molt twice in the bronchial tree. And then the immature worms are going to travel up the trachea, and then they're going to be coughed and swallowed and re-enter the GI tract that they just left. So they've entered once as they are developing, as they are immature worms. They're going to leave that colon, that cecum area, enter portal circulation, go to the liver, enter circulation again, go up to the heart, and they can do that either through venous circulation or through lymphatic vessels. They're going to enter the heart and then go out to the lungs, where they're going to spend a lot of time developing. They're going to be there long enough to molt twice, go up the trachea, they get coughed up, they get swallowed again, and then they re-enter the GI tract. They go through the stomach again. They're able to resist those gastric juices and end up in the jejunum, in that part of the small intestine where they finish maturing. It's only until they re-enter the GI system and go down into the small intestine that they are able to finish maturing. And then once they are mature, they can still live within the body for another 6 to 18 months. So what happens when you have 6 to 18 months of worms living in your body? Well, the signs and symptoms may actually be none. And this is one of the things that's really interesting about a worm that whose primary host is humans, which means that pretty much they evolved along with us to really, really form that commensurate relationship. That's what they're going for. They're not aiming to be a parasite. They're aiming to get what they need in order to survive. But they're hoping, well, evolution is hoping, that there will be as little impact on humans as possible in order to maintain the potential of a long life for the worms. And so there may not be any signs or symptoms. And that shows us how successful this worm has been. And that leads to how difficult it is to eradicate it from the world, and how well the worm itself has evolved to live with humans. So you may feel vague abdominal pain. We may see impaired growth in children. These worms are eating the intestinal contents, so they can't be absorbed. The migrating worms may cause obstructions as they are going through the digestive system. If there's a whole bunch of them, they can block it up. The tubes that the worms are going through in the hepatic system, the hepatobiliary system, are much smaller, and so they may cause obstructions there. They may divert up into the pancreas and cause an obstruction there. And the single female worms are the ones that are most likely to migrate once they are adults. And the reason for that is because, remember, we must have those fertilized eggs in order to continue the cycle. And there is a ratio of 3 females for every male. And so sometimes it can actually be difficult for a female worm, a single female worm, to find a partner. And so when she can't, she goes looking. And so then she migrates. And so these single female worms are the ones that are most likely to migrate. And that's when we end up seeing some things that can be quite disturbing. So I want to warn you right now that I am going to show some pictures of this, and it is a little bit graphic. All right, so we can see the adult worm migration tends to happen when somebody is asleep. And we can see that in this case, the female worms have attempted to leave through the nostrils and the mouth. They may also try to leave through the anus. And surprisingly, they may try to leave through the umbilicus, and that's particularly in children. And when we step back and we look at the anatomy of the body, we remember that fetal circulation, which the umbilicus is a vestigial remnant of that, connects also with the portal system. And so it's not hard then for us to realize that when the worms are leaving the lower intestine, those remnants of the fetal system are still there. And so sometimes they are able to access those, again, particularly in small children, and then leave the body through the umbilicus. On the right, you can see a bowel obstruction. These are adult worms over here that have finished maturing in the intestines. You can just see it's the sheer number of them. The sheer number of worms have created an obstruction. All right, and so treatments. For uncomplicated cases, uncomplicated means that they haven't blocked anything up. They don't need surgery for somebody to go in and take out these worms, okay? Uncomplicated cases are usually treated with antihelminthic medications, so anti-worm medications. Albendazole and mebendazole are the most common that are prescribed. Mebendazole tends to have more side effects. The way that these medications work is that they prevent the worms from absorbing sugar. And so the worms are then they sort of release their habitats. They are then expelled either upwards through vomiting or downwards through stool. It usually takes 1 to 3 days, though I did see reports of it taking several weeks. Again, that probably just depends on the amount of the load of the number of worms that are in the system. Now, the medications have very few side effects. Nausea, vomiting, again, that makes sense. We're trying to get the worms out. Headache, dizziness, abdominal pain. Those were the most common side effects. Some that I found interesting were reversible hair loss, tarry stools, again, that makes sense. You've got a lot going on right there, and skin blisters. All right, so vulnerable populations. These worms are most likely to infect children. And the reason for that is because children are dirt eaters. Children put everything in their mouths, and they are likely to be outside, find some dirt, find a toy in the dirt, find a pet in the dirt, and all of that is going into their mouths. And so these worms are most likely to infect children. We've already talked about the tropical and subtropical regions. The worms themselves tend to prefer these regions, the high humidity, the clay-like soil. But because of travel, because of immigration, because of the movement of refugee populations, it is considered a worldwide problem. You never know where these infections are going to pop up. And that's just because of this modern day travel. So in the areas where the worms are endemic, it's usually areas of poor sanitation and hygiene. Sanitation and hygiene are separate concepts. Sanitation is more the infrastructure systems, and your hygiene are your individual practices. So if somebody can have really good hygiene, they can wash their hands all the time. But if the water that they're using is contaminated, if their sanitation is poor, then their hygiene is not going to get them very far. So in these plumbing poor areas, this tends to be where you see a lot of these infections. The other is in areas where human manure is used to grow food. That is a very dangerous practice. And we can see that because anything that is in that fecal oral transmission cycle is going to potentially pass to people through their food. So how does one avoid transmission, particularly if you're in these areas? Obviously, modern infrastructure and sanitation systems are key, and investing in these is very important. However, anybody through disasters can be affected by a loss of their infrastructure. And so if a hurricane comes through, there's a disaster, there's a tornado, these leave the potential of having contaminated water where these fertilized eggs could be located and infections are possible. So it's very important that during disasters and the post-disaster phase that water is purified. And that can be done through filters, iodine, boiling, all different ways that you can purify water. It's also important to wash, peel, and cook vegetables, especially if they are grown in fields that have had manure on them, and especially, of course, if it's human manure. We also want to make sure that regular precautions are taken, washing hands after using the restroom and before eating. Now, our textbook in the class said, in the southeastern United States, ascariasis is quite common, with a reported incidence of 20 to 60% in the childhood population. So this was kind of a record scratch moment for me. What? I grew up in the South. I raised my children in the South. I have never heard of this existing in non-immigrant refugee U.S. populations at all. And I assure you that if it were in close to half of the children, people would talk. It would be on the news every night. People would panic as worms crawled out of their kids' noses. I mean, we've seen that migration. This just simply isn't the case. So the problem with this is that there is a long-standing stigma over worms in the South. It's the concept that all Southerners are dirty, that they all have worms, that Southerners are lazy. And these concepts grew out of the Victorian time period, and it primarily stems from hookworm infections. Hookworms which is a separate kind of worm, but hookworms were widely prevalent throughout the South in those prior centuries. And one of the symptoms of an intense hookworm infection is lethargy. And so before science of this was really understood, laziness was ascribed to people who had hookworm infections, of which a lot of people in the South had hookworm infections, but it was understood as a moral failing. And so there is a lot of bias and stigma that is wrapped up in the concept of Southerners and worms and laziness and moral failing. So there was a guy named John D. Rockefeller who was one of those rich barons in the had the rags to riches stories, all of these rich men who came out of the Industrial Revolution. Well, John D. Rockefeller was one of them. And he took it upon himself through his philanthropy to really address the hookworm situation in the South. The science was coming out. He wanted to invest in this. He thought it would be great for the South. And so he wanted to eradicate the germ of laziness in the South. And so he set his Rockefeller Sanitary Commission to work. So again, their primary goal was to combat hookworm infections. However, because ascariasis was an infection of the time period and did sort of exist because of the same type of factors, ascariasis was part of their work. And so by the 1960s, ascariasis was largely seen. Oh, excuse me, I skipped ahead of my thing. So these commissions would come into an area and they would help advise people on how to avoid hookworms. They would tell them to wear shoes. And most importantly, they would help them fix those sanitation systems, because remember, your hygiene practices do not matter as much if you are living in a problem of an area of poor sanitation. So the quote here on the top was from the textbooks. The quote here on the bottom is actually from the Rockefeller Sanitary Commission. Now, understand that this was at the height of the worm infections. And it says that ascariasis infection prevalence ranged from 1.3% in Georgia Caucasian children ages 5 to 15 to 49.4% in a second study of Cherokee Native American children in North Carolina ages 6 to 16. So we can see that the prevalence of ascariasis infections did vary based on the population. It did vary based on locality. It did vary based on socioeconomic levels. We can see that there are lots of differences here, and that the rates of worms were very high historically. Historically, the rates of worm infections were very high. But what about now? Rates of ascariasis now are so low that in many states, it's not even a reportable condition. It's not even worth the manpower. Okay, so when I pulled up the reportable conditions for Florida, ascariasis was not even listed on there. There's no one to report to. You just treat it, you move on with your life. Okay, but in 2016, Texas made ascariasis a reportable condition. So this does actually give us some data to look at, which is kind of nice. So Texas averages 12.8 cases per year. So it's normal for them to get about 12 to 13 cases of ascariasis a year. And the range is anywhere from 6 to 19 cases. And so these cases are assumed to be related again to immigrant populations that are coming from areas where they lack sanitation. They're coming from areas that are further down into the subtropical and tropical areas where ascariasis is more common. They're coming from areas that lack proper sanitation. And these are the cases that are showing up of ascariasis in Texas. And so it's important for us to recognize that the ascariasis rates now are nowhere near what they were during Rockefeller's time when he sent the Sanitary Commission into work. And in fact, I spoke with a public health worker who was working in rural Florida in the 1960s. And he reported to me that that even then, even in 1960, the cases of ascariasis were restricted to migrant immigrants who were coming out of areas of poor sanitation in the subtropical and tropical regions, who continued to live in poorly sanitary conditions in Florida, and that those were the only cases of ascariasis that he could remember ever seeing throughout the entire course of his public health career. So it's important to understand ascariasis infections in light of historical stigmas. Hookworms still exist in the South. Ascariasis still exists in the South, but the rates of both are deeply reduced, and ascariasis barely even occurs at all. Hookworm rates are a little bit higher. Acknowledging this fact helps us to reduce the chance of returning to historical biases. So thank you very much. Here's a list of my references that you can see here. These are all cited within the notes. And if you have any questions, feel free to drop me a note. Thank you so much. Bye-bye.